Okay, hello guys, how are you doing? So, as you might have seen in your infographics, we are supposed to have we're supposed to talk about some diseases related to some um, systems of the body. And the first one, as you can see, is well, in your infographics, it's written as the blood. Okay, it would be part of hematology, right? So these are just the basics, right? Because there are a lot of different diseases related to hematology. So what we're going to talk about today would be the basics of hematology, the easiest of all the topics related to hematology, which would be anemia. Okay, so if you have any doubt during well the presentation, just let me know. You can raise your hand, and we will solve any doubt. As you can see, there are just a few slides. However, there's a lot of information. Okay, so because when I was a student, I didn't like the professor just to read the slides. I wanted him to, or her, to explain, to know the topic that he is trying to teach, right? So that's what I'm going to try to do, okay? We already did it in past topics. So let's get started. So, um, as I was telling you, we were going to start with this topic, which is anemia. Okay, so we're going to start with a little introduction here. Okay, so what is anemia actually? It is in some other class, I asked if anybody knew what anemia was, and this person told me that it was an um, decreased count of red blood cells, right? And it is correct. However, a more accurate way of sorry, someone else just joined. So a more accurate way of talking about anemia would be decreased concentration of hemoglobin. Okay, it is more related to hemoglobin. Hematocrit, hematocrit is more related to another disease. So when you have a patient with decreased levels of hemoglobin, you are talking about anemia. And actually, the concentration of red blood cells could be useful, but it has it could be related to some sorts of mistakes. For example, when a person is dehydrated, right? When a person is dehydrated, loses water, right? And the watery part of the blood is also diminished. So the number of red blood cells would be increased, which is known as, it would be more concentrated, right? So it would be higher than normal, even though it's not pathological. It's only related to dehydration. So when we talk about hemoglobin, we are relating it directly to anemia. Okay, so anemia is actually a diminished concentration or lower concentration of hemoglobin, but we have to take into account some variables, which are age, sex, and the altitude in which this person lives. Okay. Why age? I mean, hemoglobin concentrations can vary from from people that are in different ages. From sex, when we talk about sex, hemoglobin concentrations are usually higher in men, as you already know, and altitude. Well, here in my city, I live in La Paz, as you already know. We live in high altitudes, and that's why we're talking about an example later on, but taking into account this first part, altitude does affect the concentration of hemoglobin in blood. So it is at this lower concentration of hemoglobin according to the age, sex, and altitude in which this person lives. Okay. So this looks kind of difficult. However, it's not. Okay. So as I was telling you, I'm going to explain it in a very detailed way. Okay, so you can understand. So here in my city, we live at, well, there are two ways. I'm sure you know this. There are two ways of reading this kind of numbers. The more correct way would be 3,600 meters above sea level. Okay. The other way would be 3,600 meters above sea level. Okay. Why do I say 100? Because when you write 100, it has two zeros, right? So let me, okay. So when we have two zeros, when we write 100, the number, it has two zeros, right? And here we have two zeros, just the way 100 would be written, right? So we can read it 3,600 or 3,600, okay? So it would be meters above sea level. In Spanish, 3,600 metros sobre el nivel del mar, right? So here in La Paz, we live at this altitude, and a city which is right next to La Paz is actually higher than La Paz, which is called El Alto. You might have heard of it. They live at 4,000 meters above sea level. That's really, really high. So here in great altitudes, we have a lower oxygen concentration. We have a lower oxygen tension. Okay, so that inflates in our concentration of oxygen uh, in our blood. So what happens when we have lower PO2? There's decreased intracellular oxygen pressure. Okay, so as we do not have that, well, we have lower concentration of oxygen in our blood, then what happens? I don't know if you ever read about this molecule. The HIF molecule means, well, stands for hypoxia-induced factor. So what would that mean? This is a molecule, okay, that is induced by hypoxia. Okay, so hypoxia is, for those who may not know, a reduced concentration of oxygen. So here we have this drawing, right, in which, well, what I care about the most are letter A and B. Okay, so when we have normoxia, which is the normal concentration of oxygen, this is what happens. Here we have the nucleus, okay, the core. This round structure in light blue, and this would be the white part would be the cytoplasm. Okay, so right inside our cytoplasm, we have a lot of molecules, right? One of them is the HIF. This is actually the HIF actually has two main components, okay, which are as you might have read, uh, it has two smaller molecules, okay, which are HIF alpha and this one, HIF 1 beta. Okay, that's how you pronounce these Greek letters. Alpha, just similar to Spanish, and beta. Okay, so it has this molecule has two subunits, which are these ones, HIF alpha and HIF 1 beta. So when we have normoxia, so the concentration of oxygen is normal. This is what happens. This HIF alpha, well, when this is the condition normoxia, this molecule, actually an enzyme, is in charge of destroying, let's say that way, the HIF alpha. Okay, so it is always in lower concentration because it is destroyed when there is normoxia. However, what happens when we live in some high altitude city like myself and some other student that I know that lives here in La Paz or El Alto? Okay, so what happens when we are in hypoxia? So this stimulation, this stimuli, which is hypoxia, is the main stimulation for the inhibition of this enzyme. Okay, so this HIF alpha never gets destroyed. So what happens next? It binds to the other subunit, which is HIF 1 beta. They bind together, they get together, and they form the HIF, the hypoxia-induced factor. Okay, so remember, this molecule is inside the cytoplasm. When they bind together, both subunits, they go through the nuclear membrane inside the nucleus. Okay, and what happens? Here we have some letters down below. It says HIF alpha activates the transcription of genes that increase metabolism. And here we have the important part. I'm going to see, as you can see, we have some words just underlined. Angiogenesis and erythropoiesis. Okay, so this is what we are basically talking about today. When there is hypoxia, this whole molecule is just formed by the binding of these subunits, and the HIF alpha goes inside the nucleus and goes to the gene that is in, I think it is in chromosome number 7, which, well, there is a gene which is the erythropoietin gene, okay, which is in uh, chromosome 7, and activates this gene. What is the result? The production of this hormone, which is erythropoietin. So where does this happen? And for those people who do not know what angiogenesis is, angio means vessels, right? Genesis, formation. So angiogenesis means the formation of new vessels, okay? So this HIF alpha, when it is activated, induces the formation of new vessels and the production of this hormone, which is erythropoietin. So it looks, well, this drawing looks a little complicated. However, I think it was easy to understand. Does anybody have a doubt about this? Okay, let's go on then. So where does this happen? We're going to talk about physiology now, which this was already part of physiology, right? So where does this happen? It happens in some cells that we already talked about in some other class, which is the juxtaglomerular apparatus, right? which is formed. Does anybody remember what cells this apparatus is formed by?
Mensagels.
Sorry?
Mensagels.
I'm sorry, I can't hear you.
Mensagels.
Could you write it down, please, in our chat section? So we're going to wait for your classmate to tell us if she remembers what cells this apparatus is formed by. Okay, thank you. Nope. Mesangial cells, maybe they're just around the capillaries. Okay, so mesangial cells are around capillaries, okay, inside the Bowman's capsule. However, this hormone is actually formed in some cells, which are the juxtaglomerular cells. And these cells, with some other, the macula densa, right? Both macula densa cells and juxtaglomerular cells form the juxtaglomerular apparatus, right? So here we have, well, we might have, if we had a picture of kidney that we also had in some other class, I showed you the nephron, right? So when the afferent artery reaches the glomeruli, before it reaches the glomeruli, there was a part in which the convoluted, the distal convoluted tubule got together with the artery, right? And that was the juxtaglomerular apparatus, okay? So when there is, when this artery is reaching the glomeruli, that is where this apparatus is formed, the juxtaglomerular apparatus. So when there is a decreased concentration of hemoglobin, these cells detect that lower concentration of hemoglobin and start producing the hormone erythropoietin, which goes to the bone marrow. Remember this term, bone marrow is the same as médula ósea in Spanish. Okay, so it reaches the bone marrow, takes some action, which we are going to talk about also. And the main response of the bone marrow is to release new red blood cells. Okay, so what is erythropoietin? So it is formed in the cells. It is a glycoprotein hormone. We already talked about types of hormones, right? Glyco means that it has a part of this molecule which is formed by carbs. We already know what carbs are, right? Actually, I remember, if I'm not mistaken, the carb part of this molecule is sialic acid, okay? And a part that is formed by amino acids, so there is the protein part, okay? And this is its molecular weight. So let's go on. Sorry. So what happens next? I mean, here we have a bone, right? The silhouette of a bone. So it represents what's inside this bone. It's the bone marrow, okay? So here we have some types of cells. This one in the center, this blue one, would be actually a stromal cell, okay? Which gives support to all the other cells that are around it, okay? So what happens when the erythropoietin reaches the bone marrow? Okay, here we have a square in which we have two take a closer look. Let's go on. So here we have this cell, this blue one is a stromal cell, okay? And this cell is an erythroblast, which is a predecessor, that is the word, predecessor of red blood cells, right? You already know this. So this predecessor of red blood cells is like stays inside the bone marrow thanks to these molecules, okay? You know what these molecules are. I'm going to say it anyway. These are vascular cellular adherence molecule and intercellular adherence molecule. So these molecules have one main role here. They bind together with between each other. So this cell does not leave the bone marrow yet. Okay. So what does erythropoietin do? It inhibits the production of intercellular adhesion molecules. So these molecules are not going to be produced anymore, and this cell is going to be released to the peripheral blood. Okay, what is another main way of action of this molecule? It inhibits apoptosis. And the other one is that it, as we already said, it induces the production or formation of new vessels, right? This is a process known as angiogenesis, right? So since it inhibits the production of intercellular adhesion molecules, which are ICAM and VCAM, it increases the release of reticulocytes from bone marrow, right? So these cells, you already know, are young red blood cells, right? So the young cells are released to the bloodstream from the bone marrow. And since it also, well, this molecule also inhibits apoptosis, it increases the length or duration of cycle cells. So the cells that are supposed to die, in quotes, right, are supposed to die, they live longer, okay? So they keep working in a diminished manner, but they keep working. And those cells who have some mistakes during its production are also supposed to die, right? Through this process, which is apoptosis. However, since this hormone inhibits apoptosis, these cells that have some mistakes in the structures of the cell, well, they are also leave to the bloodstream. Okay, and they do not die. And the other way of action of this molecule is that it induces the production of new vessels. So there are new pathways for oxygen delivery. Easy, right? So we also said what anemia was all about. So it is a lower concentration of hemoglobin according to sex, according to altitude, according to age, right? So what are the symptoms and signs we might have in our patients? We have general manifestations, cardiovascular, neurologic, skin, and this is in case just of severe anemia, okay? So the general manifestations, we would be talking about weakness. So you all know, does anybody not know what weakness is? Okay, so weakness is debilidad, right? This person might feel weak. So here in cardiovascular manifestations of anemia, we have shortness of breath and maybe hypertension if the blood loss was acute, right? Shortness of breath would be translated as dificultad para respirar. Also, yes, that would be it, okay? In neurologic manifestations, we have headache, dizziness. Does anybody know what dizziness is?
Mareos.
Right, Marios. This, you also know this, right? This term, which is tinnitus, in English is pronounced this way, tinnitus, okay? Which is, can anybody tell me what tinnitus is?
It's a disease from the ear.
Sorry?
It's a disease from the ear.
Okay, it's not a disease, actually. It's a manifestation, it's like a symptom, right? Yes, it does have to do with ear. Yes, it's like you have a ringing in your ear, right? Like a continuous sound, like a whistling in your ear. That is tinnitus, okay? So in skin manifestations, these are related to the redistribution of blood from non-vital organs to vital organs. I mean, skin is important. However, since we have a lower delivery of oxygen to some more important tissues, the peripheral vessels contract, right? To redirect this blood to more important and more vital organs, which are maybe the brain, kidneys, etc., right? So since the peripheral vessels contract, they do not receive that much of blood, and we have a pale skin, paleness, palidez, right? This one is also related to it, fragile nails, right? And in case of severe anemia, we also might have wet and cold skin, decreased urine volume, and chest pain in some really severe cases, okay? These are the manifestations, symptoms, and signs that we might find in a patient with any kind of anemia. However, you all know that there are a lot of types of anemia, right? So according to a certain type of anemia, we might also have some different manifestations, okay? For example, in iron deficiency anemia, we might have koilonychia. Does anybody know what koilonychia is?
Es la para las manchas blancas en la uña, ¿no?
Nope. Actually, koilonychia means like you have the the nail is actually has the form of a spoon, okay? The shape of a spoon. Does anybody know what a spoon is? S-P-O-O-N.
Cuchara.
Yes, great. Koilonychia means nail that is, well, has the shape of a spoon. Okay, so that is related to iron deficiency anemia, which is the most common type of anemia, right? And this is also interesting. Does anybody know what pagophagia is? For extra points, guys, come on. 5, 4, 3, 2, 1. Okay, nobody. So pagophagia is actually the craving. Does anybody know what craving is? C-R-A-V-I-N-G. Craving. For example, I'm going to give you one sentence for you to know.
Like you desire something.
Yes, great. That is correct. So you have the cravings for ice. Okay, you have the need to put ice into your mouth. That is pagophagia. Okay, they are both related to iron deficiency anemia. besides all of these general manifestations of anemia, okay? And about this one, hemolytic anemia, okay? We also talked about this term yesterday. I think it was Valeria, right? Uh, what is jaundice?
That you have yellow skin.
Yes, great. The yellowish skin and sclera. So in Spanish would be ictericia, right? So jaundice is that. Okay, jaundice means ictericia. So when we have hemolytic anemia, we also have all these clinical manifestations, and we also might have jaundice. Okay, piece of cake, right? Let's go on. So here we have what is called anemic syndrome. This anemic syndrome is what you should, well, when you go see a patient and this patient is weak, has pale skin and mucosa, shortness of breath, headache, dizziness, and tinnitus, this person has anemic syndrome, okay? You do not write yet anemia because you are going to confirm the diagnosis of anemia when you get your labs, right? Until then, you only have anemic syndrome. Okay, let's go on. So how do we study anemia? You also know about this. I mean, we are going to have some laboratory studies, right? And these are the ones that are in red are the three that you're going to get your report with. Always. You always get your red blood count, red blood cells count. You always get your hematocrit, that is how it's pronounced, and the hemoglobin. Okay, in case you do not know what this is, hematocrit is the percentage of red blood cells that your blood has. Okay, and hemoglobin is just the molecule, right, which is inside each red blood cell. So these are the primary red series values. These are the secondary ones, the next three. Corpuscle mean value, corpuscle, I'm sorry, there's a mistake here. It's CLE, right? Corpuscle mean hemoglobin and corpuscle mean hemoglobin concentration. Corpuscle mean volume is also known as CMV. Corpuscle mean hemoglobin, it's also known as CMH. And corpuscle mean hemoglobin concentration is also known as CMHC. So what does anybody know what this one first is? In Spanish would be volumen corpuscular medio, right? Can anybody tell me what this is all about? Come on, guys, volumen corpuscular. Yes.
I think it's the size of the red blood cell.
Yes, great. That is the size, yes, of each one of the, I mean, it's the size in, let's say in femtoliters. We are talking about volume, right? So we relate it to a volume measure. So we will be with liters, right? In this case, since this is a red blood cell is so small, we have to talk about femtoliters, which is much lower volume, right? Great. Yes, this would actually mean we would talk about CMV when we refer to the size of each red blood cell. Great. What about this one? CMH.
Is
the
the
average?
concentration of the hemoglobin in each red blood cell?
Great. Yes, the concentration of hemoglobin inside each one of the red blood cells, right? And this one is like a percentage of the CMH, which is divided by the hematocrit. Okay. So, and this one, does anybody know what red cell distribution white is? In Spanish, we call it amplitud de distribución eritrocitaria. Does anybody know what this is all about? Okay, so this is actually the percentage of variation of the size of a lot of red blood cells. Okay, so it is normal that a lot, as you know, we have a lot of red blood cells, right? And they can vary in size from 11 to 15%. Number that is lower than 11, I mean 10 or lower, or 16 or higher, is pathological. The normal variation of sizes between all the red blood cells is between 11 and 15, okay? So with these values that you have reported in your lab study, we can have this, the Winthrop index, okay? What are these? This is, well, they are just formulas. If you only have these three ones, the red blood cells count, especially hematocrit and hemoglobin, you can have some components of these formulas and get your CMV, CMHC, okay, using just these ones. Sometimes here in La Paz, I've seen some lab reports with only the values that are in red. However, I can have all the others, the next three, with these formulas, okay? So this CMV, what your classmate just told us, talks about, well, tells us about the size of each red blood cell, right? So it can give us the morphologic classification of anemias. It is, well, a normal range of, well, how big is a red blood cell in terms of volume between 80 and 100 femtoliters, okay? So when it is lower than 80, this one, it's called microcytic anemia. And when it is higher than 100 femtoliters, it is a macrocytic anemia, okay? Micro and macrocytic anemias. And when we talk about CMHC, if the concentration of hemoglobin according to the percentage of hematocrit, well, the normal range is between 32 and 36 picograms, okay? When the blood of the patient has this concentration of hemoglobin, it is there is a spelling mistake here, is normochromic anemia, right? And when it is lower than 32, when we have hypochromic anemia, we do not have hyperchromic anemia, right? Because that wouldn't be anemia. We only have hyperchromic and normochromic anemias. So we're going to talk about the morphologic classification later on, okay? So here we have the morphologic classification. We already talked about the microcytic, lower than 80, normocytic between 80 and 100, and macrocytic higher than 100, right? It is actually standard value is from 83 to 100. Okay. However, for you to remember in a better way, for you to have a standard values, and it's easier for you to remember, we're going to take into account from 80 to 100 femtoliters. Okay. So we already talked about this one. And what about this one, the pathophysiological classification of anemia? Well, first of all, we're going to talk about the peripheral blood smear. Does anybody know what this is? Peripheral blood smear. We already talked about it yesterday, I guess. Anybody? Okay. So a peripheral blood smear is translated to Spanish as frotis de sangre periférica. Okay, so this is frotis de sangre periférica, peripheral blood smear. Okay, so here in this study, we just take a blood sample, a peripheral blood sample, and see it under the microscope. Oh, of course, we have a technique, right? An appropriate technique in which we can see directly the blood cells, all the blood cells. However, we can see the morphology of red blood cells. In this case, this one would be a normal red blood cell. This would be a macrocyte, which is bigger than this one, right? So this is a macrocyte. Microcyte, it is smaller than the normal one. Elliptocyte, because of its shape, right? A target cell, in which we have a point in the middle, like a target, right? A teardrop cell, because of its shape. Teardrop means lágrima, right? So in Spanish would be dacriocitos, remember, right? Sickle cell is like a red blood cell that has been destroyed, and some parts of it, you can see it in your peripheral blood smear, okay? Acanthocyte is almost the same, and spherocyte, as you can see, it does not have a thinner part in the center. So it's like a balloon, like a ball, okay? These ones are not round. They're, well, as you already know, they are like flat, but when you see it in front, they're roundy, right? However, this is like sphere, completely round. So we can have this different morphologies of red blood cells in our peripheral blood smear, okay? So when we talk about the pathophysiological classification of anemias, we have to talk about the central and peripheral anemias. So you all know that when we are talking about red blood cells, they come from predecessors that are younger versions of a mature cell, right? And the previous step from a normal or a mature red blood cell is a reticulocyte, right? However, when we get the report from the laboratory, they just tell us the percentage of reticulocytes that are in that sample of blood. So what would we have to do? We're going to see that later on, okay? So here we have the morphologic classification. Here we have normocytic and normochromic anemia because of the size and the content of hemoglobin, right? Microcytic and hypochromic, which would be related to the size and the lower concentration of hemoglobin, right? And macrocytic, in which the cells are bigger than normal, right? So here we have regular and normal cells, red blood cells. Here we have smaller and pale cells. They're not as red as these ones. They're kind of decolored, right? And the macrocytic, in which they are bigger than normal. So as I was saying, what do we have to do when we have when we want to use the pathophysiological classification. So we have the normal ranges. Well, we have the reticulocytes count and the reticulocyte index. Okay, so it tells us the red blood cells production. Why? Because they are the previous step for a mature cell, right? So what is the percentage of reticulocytes found in a peripheral blood sample from 0.5 or 0.5 to 1.5% of all the red blood cells should be reticulocytes, okay? And this is how we get our report from the laboratory in percentage, okay? So what do we have to do here? We have to get our reticulocyte production index. And how do we get that? Because this is like, it's not that accurate, okay? When we have our percentage, we have to get first our reticulocyte index. Because for this formula, for the production index, we have to get first our reticulocyte index. And how do we get our reticulocyte index? We have a percentage reported by the lab, right? So we write down this percentage right here and multiply this percentage by the patient's hematocrit, divide all this both numbers by the normal hematocrit for a person's age, sex, and altitude, that we all have different levels, right? And multiply it by 100. That's how we get our reticulocyte index, okay? And after that, we can even go further to get a more accurate value. Since we have our reticulocyte index, we can get our reticulocyte production index, which is the reticulocyte index divided by 2. And there we get our percentage. So when we have our reticulocyte production index, if the result is lower than 2, it is an anemia that is related to bone marrow. What does it mean? It means that the bone marrow is not producing enough red blood cells. So the problem is peripheral in the bone marrow. If the reticulocyte production index is higher than 2, this anemia is not related to bone marrow. Okay. Easy, right? This is the pathophysiological classification of anemias. We also can classify the anemias. This one on the left is according to the World Health Organization, okay? And this is I don't quite remember the name of this classification. However, it relates to the hemoglobin concentration. As you all know, a severe anemia is lower than 8. So from 7.9 to 6, which would correspond to a 3rd degree anemia, is also related to severe anemia as long as 4th grade. Okay, it will be useful for you, especially at university, this kind of graphics. So what is the diagnostic approach? If we get microcytic anemia, which means that it has a mean corpuscular volume lower than 80, what do we have to do? We have to get our RDW, which I already told you what it is, the variation of size of a lot of red blood cells, okay? If it is higher, the variation of size is higher than 15, and we have an MCV lower than 80, our diagnosis is iron deficiency anemia. Okay. If we have an MCV lower than 80 and we have a normal RDW, we have our diagnosis, which is thalassemia. Easy, right? This is what we use it for, to differentiate microcytic anemias. This one is useful for that, okay? When we have a normocytic anemia, which means that we have a VCM, normal VCM, which corresponds to between 80 and 100, we would be talking about some of these diseases. When we have chronic kidney disease, anemia, we have a normal VCM because one of the functions of the kidney, as I told you, is to produce this hormone, which is erythropoietin, right? So it does not produce this hormone, and we start getting lower counts of red blood cells. That is what this anemia comes from, okay? Hemolytic anemia, I mean, when this is present, all the, well, patients who have this kind of anemia have a normal concentration of anemia, and they are just normal red blood cells, right? But they get destroyed by any cause. So they are just normal cells. That is why it has a normal VCM. And if we have hemolytic anemia, because we would think about it when we have anemic syndrome and jaundice, right? What will we have to do? We have to take hand of this test, which is Coombs test, right? Which tells us if it is autoimmune hemolytic anemia, if it's positive, and if this Coombs test is negative, we can think of two options. Red blood cells membrane defects, okay, as in the case of spherocytes, right, which is yeah, well, actually the disease would be spherocytosis, right, and microangiopathic hemolysis. Okay, if it's negative, we can think of these two options. And in our peripheral blood smear, we get schistocytosis. So if we have an IPR that I already talked about, higher than 2, and we have an increased indirect bilirubin, because we remember we have jaundice here, right, related. If we have decreased aptoglobin, which is, what is aptoglobin? It's a protein that is produced in the liver and helps to transport iron, okay? So when this is decreased and the LDH, this is an enzyme, is increased, and an increased indirect bilirubin, and we have an IPR higher than 2, we can think of these diseases, okay? Especially in hemolytic anemia. What about when we have a VCM higher than 100 femtoliters? We actually have the diagnosis of macrocytic anemia, right? It would have some causes like inefficient erythropoiesis. There's a misspelling here. There would have to be an H between the T and R. And nutritional deficiencies such as deficiency of B6 and B12 vitamins. There would have to be a bone marrow primary disease, in which the main cause of the disease is inside the bone marrow, liver disease, and hypothyroidism. And when we have VCM higher than 100, we are already talking about megaloblastic anemia, as you already know. So guys, this would be it. This is just the basics of anemia, because you all know that there is a ton of different types of anemia, right? Just the most common one would be iron deficiency anemia. That is a whole new world. There's a lot of information about it. We do not have that much time because this is actually one topic about hematology, right? And just the basics. And if you see your infographics, there are a lot of topics to talk about. It is, for example, just written DI. There are a ton of diseases that are related to the eye, or cardiac diseases or lung diseases, and there is a ton. So we're going to talk about one per each specialty or one per each organ that is in your infographics. Okay, so as we already talked about it, does anybody have any doubt?
No.
Okay, guys, please, the daily poll, okay? So I'm going to do it right now. Let me know when you're done. Tomorrow, well, as you might have seen, it's a lot of detailing here. So if we talk about this kind of knowledge tomorrow, it's going to be a lot. So if you can read about anemias in just a little, that would be great.
Okay.
Okay, guys. And if you have any doubts, by tomorrow we're going to talk about them, okay? Since we have our practice class. Please wait, do not leave. I'm going to take a picture of the people that are present because we have a lot of people who are not. Just give me a second. Mm, Okay, guys, I think that would be it. Thanks for your attention and I'll see you tomorrow, okay?
Okay, see you tomorrow.
Okay, have a good night and bye.